Welcome to the deep dive. Today we are really jumping into the neuropharmacology of sleep and wake disorders.
Yeah, this is a big one.
It is. And our mission really is to get past just, feeling tired.
Right.
We're going to start treating sleep as what it is, a core psychiatric vital sign.
That's the perfect way to frame it. The whole conceptual framework, the way we need to think about this is the arousal spectrum.
The arousal spectrum. Okay, so not a switch, but more like a dimmer.
Exactly, a dimmer. And the goal is to be right in the middle, in that sweet spot of normal alertness.
So what happens if you crank that dimmer way too high?
If you go too far to the right, you're in the zone of excessive arousal. During the day, that might feel like hypervigilance and anxiety. At night, it's just plain insomnia.
And the treatment is to push you back down the spectrum.
Right. You need a hypnotic to move you back towards sleep.
And if the dimmer is too low, you're too far to the left.
That's deficient arousal. You'll see cognitive problems, brain fog, and in the extreme, excessive daytime sleepiness, or EDS.
And so the goal is to use wake-promoting agents to push you back up.
Exactly. What's so interesting is that both extremes mess with your thinking. You have to be optimally tuned to function well.
And that tuning is all done by the ascending reticular activating system. Let's list the players, the neurotransmitters involved.
Okay, you've got histamine, orexin, sometimes called hypocretin dopamine, norepinephrine, serotonin, acetylcholine, and then the big inhibitor, GABA.
That's quite a roster.
It is. But to really get it, you have to start with the two systems that kick things off and keep them stable. Histamine and orexin.
Okay, so let's unpack histamine first. Most of us just think, allergies, runny nose.
Right, antihistamines.
But in the brain, it's a totally different story. It is a potent promoter of wakefulness. And wait a second, is it true that the entire supply of histamine neurons in the brain comes from one single spot?
It is. A tiny cluster of cells called the tuberomammillary nucleus, the TMN, in the hypothalamus.
Oh.
And from that one spot, they project out everywhere. And the way histamine works is pharmacologically fascinating. There's no reuptake bump.
No vacuum cleaner to suck it back up like with serotonin.
None. It's just broken down by enzymes. This means it diffuses really widely, making its receptors incredible drug targets.
So let's talk about those receptors. The first one is the H1 receptor.
Right, that's the postsynaptic one. You activate it, you feel alert and awake, you block it.
You feel drowsy. That's how Benadryl works.
That's exactly how it works.
But then there's the H3 receptor, which is so much more elegant. It's the gatekeeper.
Yes, it's a presynaptic autoreceptor. When histamine binds to it, it basically tells the neuron to stop releasing any more histamine.
So it turns itself off.
It does, which means if you want to promote wakefulness, you don't give someone histamine. You give them an H3 antagonist.
You block the off switch.
You block the off switch, and the neuron just starts firing, releasing its own natural histamine. It's a very clever mechanism.
Okay, now for the second system, orexin or hypocretin.
Right. And just like histamine, it comes from one tiny area in the hypothalamus. But its job is different.
It's not just about arousal.
No, it's about stabilizing arousal. Orexin is the master conductor of the orchestra. It sends out a constant tonic signal to all the other wake centers.
The ones we listed: dopamine, norepinephrine, serotonin.
All of them. It keeps them all firing in sync to hold the brain firmly in the awake state.
Which leads us right to a huge clinical insight. If the conductor is gone, what happens to the orchestra?
Chaos. And that is the basis of narcolepsy. In narcolepsy, those orexin neurons have degenerated. They're gone.
Which explains why people with narcolepsy can't maintain a stable state of wakefulness.
Exactly. And on the receptor side, it's the OX2R that seems most important, especially its connection to the histamine system in the TMN.
So we have the players, the circuits are there, but what's the trigger? What, flicks the switch every day?
It's really a daily battle.
A battle between two forces.
Exactly. You have the homeostatic sleep drive.
Which is like the brain's bean counter for fatigue.
Perfect analogy. It's driven by the buildup of a chemical called adenosine. The longer you're awake, the more adenosine builds up, the more pressure there is to sleep.
And fighting against that is the circadian wake drive,
which is driven by light. Light hits the eye, signals the suprachiasmatic nucleus, or SCN, which then tells the orexin system to keep you awake.
So when does sleep actually win?
It wins when the circadian drive starts to fade in the evening, and that adenosine buildup gets high enough to finally activate the master sleep switch.
The ventrolateral preoptic nucleus, the VLPO.
That's the one. The VLPO flips on and releases a flood of the inhibitory neurotransmitter, GABA.
And GABA just shuts everything down.
It suppresses all those wake-promoting centers we just talked about.
Yeah.
Orexin, histamine, all of them. and that's sleep onset.
And once we're asleep, it's not just a flat line. We go through these 90-minute cycles, the ultradian cycle.
We do, and the neurochemistry is constantly changing. GABA stays high all night, pretty much. Orexin drops in the start of sleep and then slowly climbs back up.
But the really wild part is what happens with acetylcholine.
It's amazing. Acetylcholine levels skyrocket during REM sleep.
Which is exactly when we have our most vivid dreams.
Precisely. Meanwhile, all the monoamines, dopamine, the norepinephrine, serotonin, histamine, they're at their absolute lowest point during REM. The brain is in a completely different state.
And getting that restorative sleep is so critical.
The cost of not getting it is huge. After just 24 hours without sleep, your cognitive impairment is basically the same as being legally drunk.
And it's not just about your brain. This is where everyone really needs to pay attention. It messes with your hormones.
It does. Specifically your adolate hormones.
Yeah.
Levels of leptin, the hormone that says I'm full, go down.
And levels of ghrelin, the one that says I'm hungry, go up.
So a sleep-deprived brain is basically being told it's starving and needs to store fat. This directly increases the risk of obesity, type 2 diabetes, heart problems. It's a massive cardiometabolic threat.
Okay, let's shift to the clinical side. Let's talk insomnia.
Right, which is basically excessive arousal at night.
It's not that you can't turn on sleep. It's that you can't turn off wakefulness.
That's a great way to put it. And the DSM-5, it made a key shift here. Insomnia is now officially a comorbidity.
It's not just a symptom of depression anymore. It has its own life and feeds back into the other condition.
Exactly. Now, for treating it, we have two main pharmacological strategies. The first is the classic one, enhance the brain's sleep drive.
Which means boosting GABA.
Right, using GABA, positive allosteric modulators, or PAMs. These are your benzodiazepines and the newer Z drugs, like zolpidem.
And the big difference there is specificity, right?
Yes. The D drugs are much more selective. They mostly hit the GABA alpha-1 subunit.
Which is the one linked to sedation.
The hypnotic action, yes. The non-selective benzos hit alpha-1, but also alpha-2, alpha-3, and alpha-5.
And those other ones are responsible for the other effects, the anti-anxiety, the muscle relaxation, but also the memory problems and dependence risks.
Exactly. By targeting just alpha-1, the Z drugs aim for pure sedation with fewer of those other issues.
Okay, so that's strategy one. What's the newer approach?
The newer approach is to just ignore GABA entirely and focus on turning down the arousal system.
By blocking orexin.
Correct. These are the Dual Orexin Receptor Antagonists, or DORAs. Drugs like suvorexant. They're a huge advance because they don't have the same dependence or amnesia risks as the GABA drugs.
And the mechanism is so neat. They're reversible inhibitors.
It's very elegant. At night, when your natural orexin levels are low, the drug's blockade is strong.
So you fall asleep.
Right. But as your orexin levels start to naturally rise in the morning to wake you up, they start to compete with the drug.
And they kick it off the receptor.
Basically, yes. So you wake up more naturally instead of being groggy because the drug is still suppressing your brain.
And we also have other non-GABA agents like trazodone or very low-dose doxepin.
Both work, in part, by blocking that H1 histamine receptor. Just powerful, non-addictive ways to turn down that core wake signal.
This brings up a really crucial clinical point you mentioned, the Goldilocks solution.
The Goldilocks solution, yes.
It's not about half-life. It's about how long the drug stays above a certain therapeutic threshold.
Exactly. It has to be just right, which is about 8 hours for most people.
If it's too long, too hot, what happens?
That's when you get the next day hangover. The drug is still working when you're trying to drink your coffee. Think of something like flurazepam.
And if it's too cold, meaning it wears off too fast.
Then you wake up at 3 in the morning and can't get back to sleep. That's a classic issue with very short-acting drugs like triazolam.
So you have to match the drug's profile to the patient's specific problem, falling asleep versus staying asleep.
That's the art of it.
Okay, let's flip to the other side of the spectrum. Excessive daytime sleepiness, or EDS.
Deficient arousal. And the first thing you always have to rule out is obstructive sleep apnea.
Right, CPAP is first line for that.
But for the primary disorders, like narcolepsy, we're looking at wake-promoting agents.
Starting with the one we all know and love, caffeine.
And its mechanism is totally unique. It's an adenosine antagonist. It literally blocks the receptor for that fatigue chemical we talked about.
So it's not a true stimulant, it's more of an anti-sleep agent.
That's a great way to think about it. Then you have your classic stimulants, amphetamine and methylphenidate. Very effective, but they're controlled substances for a reason.
Which led to the development of modafinil and armodafinil.
Right. These are dopamine transporter inhibitors, but they're designed for a slow, steady increase in dopamine.
More of a tonic effect, not a phasic spike.
Precisely. That tonic activity promotes stable wakefulness without the big rewarding rush that's linked to abuse potential,
And then the newest kid on the block is pitolisant.
which uses that cool H3 antagonist mechanism we talked about at the beginning. It's non-controlled and works by telling the brain to release more of its own histamine.
Finally, we have to talk about the most counterintuitive treatment of all, sodium oxybate, or GHB.
It's a fascinating one. It's approved for narcolepsy, but it's a powerful sedative.
You treat daytime sleepiness by making someone sleep harder.
That's the theory, and it works. It dramatically enhances deep, slow-wave sleep. The idea is if you can get truly restorative sleep at night, you won't be so profoundly sleepy during the day.
What a paradox. Before we wrap, let's just touch on circadian rhythm disorders.
Right, like delayed sleep phase, where you're a night owl. Those are about resetting the clock, not just forcing sleep.
So you'd use things like melatonergic agents, Ramelteon, or carefully timed bright light therapy.
Exactly. You're trying to shift the entire rhythm, not just treat a single night.
So this whole deep dive, it really boils down to a fundamental dichotomy, doesn't it?
It does. It's excessive arousal in insomnia versus deficient arousal in EDS. And our treatments are all about targeting these very specific networks, histamine, orexin, GABA, to try and nudge that arousal spectrum back into balance.
And knowing this empowers you to understand the connection between your brain chemistry and your overall health. I mean, we can't forget that link you mentioned.
The leptin and ghrelin disruption.
Right. Disturbed sleep directly impacts your metabolism. This isn't just about feeling alert. It's about your long-term cardiovascular health.
It's all connected.
Absolutely. And this knowledge helps you see sleep as something you can actually manage. And while these medications are powerful, we should always remember the foundation.
Non-pharmacological approaches, good sleep hygiene, cognitive behavioral therapy for insomnia. Those should always come first.
A perfect place to end. Until next time, keep digging deeper.